So on introduction, when we talk about stoma and preoperative preparation, is that we all know that stoma is a word that has been derived from a Greek word that means basically a mouth or an opening. So an ostomy is an opening on the body surface where an organ is brought to the exterior. It's where that part of the small intestine or even large intestine have been extricated outside on the abdominal surface. So what is ostomy on itself? Ostomy and stoma have been used synonymously, whereby, but in ostomy is a word ending on a suffix. That means that a surgical operation has been made in a structure to divert the direction of flow of the abdominal content. So many at the time when we talk of a stoma or when we hear of a patient being referred to as a stoma nurses, prepare him or her for the surgery, what comes to our mind is that an ideal stoma that will be developed, that will be extruded outside. It will be normal in color. It will be 2 centimeters above the skin. The mucocutaneous junction will be intact. And actually, this is what we have been desiring to have. You see, like this stoma, these are well-sited stoma, well-constructed, well-sited. We can see it has all the normal characteristics of a normal stoma, however, it's 2 centimeters above the surface. Looking at the mucocutaneous junction is intact. And therefore, if we manage this patient well, they'll go home well, the mother will be able to take care of the baby, and then home. And just to mention that in our presentation today, we are looking at the preoperative management of this patient. This presentation on ostomy care, it will be in a series. We'll look from now preoperative management. We go to intra and postoperative thereafter, not today. So plan to follow on this series. But now what happens when we think of a stoma and a patient goes to theater and now they are back? This is now what we get. In our mind, we had thought of that well-defined stoma that you'll only require a measuring guide and you'll be able to cut the bag to fit that stoma like the previous one that you have shown. This one is so easy, you don't need to trace. But most of the time when they come from theater, this is the stoma that we get. Now it doesn't have well-defined edges, and therefore our measuring guides might not help us in applying back to this patient. And as a result, what we need to do, we need to introduce other techniques. That is why we need to trace the bag, to trace the stoma itself. Then you transfer that tracing to a bag such that you can get a good bag, or you can cut the bag to fit the stoma well. Now looking at this on the mucocutaneous junction, we can look at it and see and also appreciate that one thing, it is still intact. However, it is at risk of tearing down or tearing apart. And therefore, we need to keep this area clean. Show the mother, if it's another, show them to take care of this junction. Because if we don't, the mucocutaneous junction I'm referring to is the gap or the bridge between the two stomas. And also around the stoma, it is intact. It has to be intact so that the stoma can be well held outside. If the mucocutaneous junction gives way, then it means the stoma will now have nothing to hold it out and it will retract back. As it retracts back, it's very hard to apply a bag. And so what happens, the effluent coming from the stoma will spill over the skin, causing skin excoriation. Now, this is what we mean by skin excoriation. You can see this patient. I don't know whether you have a pointer. Okay, we don't have a pointer for this one, but low is. Thank you. So this is the mucocutaneous junction I'm talking about, this bridge, and also around the stoma around. It has to be intact to retain the stoma 2 centimeters above the skin. But what happens if we don't take care of the mucocutaneous junction and also the junction around the stoma? This is automatically now what happens. One thing is that the stoma will retract back. You see 2 of them. And just to note, why we have 2 of them, it's because we have one which is active and the other one is the mucus stoma, or one is distal and the other one is proximal. So for the proximal one, this is the most active. The distal one is the mucus stoma. So if you don't retain your mucocutaneous junction well, you don't clean around well, and when you are cleaning, you're just using, it's a clean procedure. We use just clean water, avoid hot water, and avoid normal saline. The recommended one is just tap water clean around with a piece of cloth. So when we get to this stage, it becomes a problem managing either a baby or even an adult with this skin exfoliation here around. Now, another bad practice that we should do away with all over is the fact whereby we are using gauzes to manage the effluent. If you use the gauzes to manage the effluent, gauzes are not super absorbent. And so what happened, the effluent spills around the skin, causing exfoliation. And especially in ill patients with ileostomies, the effluent has a lot of acid content and it will burn the skin around. So it's our desire now that this one has happened. We need to help the mother to understand how we are going to handle this one. And that's why today we want to look at the preoperative preparation for the mother or any patient going through this surgery to realize that one, we can get very good stomal, which is a good trade-off of the condition that they are having. However, if not well managed, the patient will end up with such a thing, and both the mother and everyone will be in a crisis. So this is again the same patient now looking at the skin exfoliation. You can even now see the mucocutaneous junction has given way. We can see the fecal matter around this one. It is still causing erosion of the skin around. And now as a result, the bridge between here, the two stomas, which one, the one we say that is proximal and the distal, it's now retaining the data. And most of the time, once it's giving now this abdominal content start turning into the abdomen. So this is not our desire as stoma nurses. We desire to have the one that we had the initial one. So to proceed now, what about when an adult? When an adult is referred to you after the surgeon has made a diagnosis that this patient requires a stoma, this is what you desire, or this is what comes to your mind or to my mind, that we will extract a very nice, or we have a very nice stoma, and the patient will be able to resume his normal duties as soon as possible, and the patient will be able to apply the bag, because most of them, so the stomas that we have the stomas that are permanent and others temporary. Temporary are the ones that are done, however, reversed later, especially probably in patients with the Fournier's gangrene. If they have a Fournier's gangrene and you want the wound to heal well, that is the perineal region, you divert the content or you divert the waste through a temporary stoma, which after some time when the wound heals, it's reversed. However, a patient with a, for example, cancer of the colon, when a stoma is extracted or created, at the end of the day, they have to live with this stoma as long as they live in this world. And therefore, as we discharge home, we want to discharge them home stable, able to take care of their stomas, able to apply any appliances that we need. So that's our desire in an adult. But so what happened in this sense? This is how now the stoma looks. This is the abdominal wall. This is the stoma that has been extracted out. Good to notice that it's deep red, that is the color. Look at the incision site of the wound. It is centrally located. That's our desire. But what happens in some of the cases? Your desire was this one, or to have a good stoma like this one, but post-operative, you get it like this. Now, this one, just to note where it has been located, it has been located and sited at a very difficult area to manage for applying a bag. It is near the iliac crest, which is very bad. And therefore, at the end of the day, we'll be looking at how do we site the stomas and which is the best location to site this one. Because this patient is, if the stoma is sited near iliac crest, the moment you apply a bag, and the patient now tries to wake up from a sitting position or a lying position, the bag or the appliances detaches from the skin. So when it detaches, the content starts spilling over the skin, causing skin exfoliation. And it's very hard for this patient to manage the stoma at home. Again, this is another one. Remember, our desire was to have the initial one, this one, such a thing. But now, at one point, we end up having a stoma like this. And remember, as you manage this one, the patient is still looking at you, looking at your facial expression, how disappointed you are, because you're applying a bag and the bag can't stick. And then this is a good stoma. However, there's a necrotic area here. The patient will be concerned, I'll be concerned. So these are some of the complications we get thereafter, and therefore we should be ready to nurse or to manage this complication as they work. And for us to manage this one, we require a multidisciplinary team of nurses, that is tomotherapy nurses, doctors, everyone is involved so that we can bring the quality of life these patients require to live. And another one that you can get is this one. You see there's already a lot of escalation of the skin. Now the mucocutaneous junction gave way. The stoma is left hanging around, and this is causing a lot of mucocutaneous, peristomal escalation of the skin. If you look at this red area, it's very hard, difficult to touch, very painful to the patient. So these are some of the challenges that you have been getting around, and therefore we feel that if we can do proper preoperative care or education to the patient and also to witnesses who are taking care of this patient, working together with the doctors, even when we are doing the stoma sighting, it might help us avoid some of these complications. Yeah, now you can imagine this is the same patient. Now you have gone there, you want to go and apply the bag, you want to clean. So you go clean, remove the bag that was the existing there, and looking at the surrounding shows that there was somebody who had thought of this patient. He or she was trying to use some materials like hydrocolloid just to preserve the integrity of the skin. So you go clean your surrounding with it's a clean procedure. You clean around with and then you make it dry. Now you want to apply the bag. But just when you have cleaned the surrounding, this happens. You know, after cleaning and with the skin exfoliation around here, how we can manage this skin, now you go a step higher where we need to use a stomaadhesive powder. So stomaadhesive powder helps to soothe the skin around and also help the hydrocolloid face of the bag to stick well. So this is how we do it. This is the powder. Somebody is applying the powder there around. It's very comforting to the patient. But remember, this is an ileostomy, can be frustrating sometimes if you're not careful. Just when you have cleaned there and you have dusted, then you're here on the side now preparing the bag. And now looking at this time, these are patients now, we are not even using a normal bag. We have to use a wound bag because the wound now is too big for normal bags to fit. So these are person who's really trying to get a good bag. And this bag now, the moment you get to this stage, the bag becomes very expensive for the patient and the patient might not afford. They start getting frustrated, giving up in life. So when you're preparing bag here, and you remember you have already dusted, put your powder there, and now you're here aside now preparing the bag. Now you want to go to apply the bag. When you look at the patient, you find like this has happened. The effluent now, after cleaning, now has come out. It is too much now that it is even washing away your powder. You feel a bit frustrated. So you need to know how to deal with this one. And especially if you're doing stomach care or stomach care immediately after the patient has fed, especially patient with ileostomy. And most likely the patient has fed on porridge or tea. Remember, the output of the effluent will almost come immediately because it's at the ileum, absorption has not taken place. So you feel frustrated, you're going back to apply the bag and now the effluent has washed away your powder. So what do? You need to be a bit innovative. So what do you do now? You need now to dust again or clean again. You apply your stomaadhesive powder and now try to use a gauze to absorb the effluent just in case it comes around. We can also appreciate the idea this person who had around. These are hydrocolloid sheets. The hydrocolloid is a nice material because it has both hydrophilic and hydrophobic region. The inner area is hydrophilic, it's water loving, and therefore it tries to absorb any moisture around that area that has skin exfoliation. The other top area is watery. So this is how you try to improvise. You put your gauze there. Now you go back and pick your bag. When you pick your bag, you come back to apply. Now you need to remove the gauze that you had put there. Now this is a bag you're holding. You want to place it. So you are successful. You now there's no effluent coming out. Your hydrocolloids are well placed and they are dry. And the effluent now is not there. It has been slightly absorbed by the gauze. So here is the bag you put. Now you put your bag properly there. Now remember this patient in this position. We ask ourselves, is this patient going to be in this position forever? This patient might stand. And again, this is the patient in the ward. The doctors have ordered for investigations. There's X-rays to be done and so on. And even patient has to go for dialysis. So once you feel you have done so well, you have put your bag there, the effluent, now you have controlled it, you're doing well. So you remove your gloves, wash your hands, and now you leave. Just even before you leave the unit, probably if you've been called from another unit, now this is after you're applying the bag. See how clean you have left the patient. But slightly before, less than 5 minutes, you have left the patient comfortable. The patient needs to go to a new unit. As they try to lift the patient up, your hydrocolloids that have attached this bag to the skin, they are off. And therefore you have to be called again to come and fix the bag again. for you to repeat the same procedure. Remember, it's the procedure that you had spent like 2 hours working on. Now you have to come back. You even feel frustrated. Now you don't even have time because you have other patients to take care of. So bottom line, if there's good preoperative preparation for this patient, where all the team are involved, probably we might be able to arrest some of these cases as early as enough. And our desire is that even if this patient is this much, we still have medication or appliances to use. And at the end of the day, we'll be able to discharge this patient home looking good with his bag, adapting back to his life, able to dress well and continue with his life. So this is all our desire. So let's do preparative care for a patient well so that we can let them go home like this. And again, now we look for that now the patient has been discharged home with a normal stoma bag. Now there's a lot of innovation going out. There are even stoma bags or stoma caps that are coming with very, very nice colors. And remember, COVID taught us a lot. Initially, we used to have only the green mask. Right now, you're seeing a match whereby you can match a dress with a mask. So can you also have probably innovation whereby we can have bags that are looking beautiful like the dress someone is on? And therefore that now brings us the zeroing down to our presentation today, where we want to look at now, what education do you give to the patient? What counseling do you offer? And then we need to know whom do we need to identify in the care of this patient. And then we look finally at the stoma site selection. Where do we put our stomas? So just like an introduction, like here, we should appreciate that there are many adults and children, they're outside with the GIT and urinary stomas, all continent diversion, who are enjoying their happy life there outside, depending on how they were taught and whether they're able to handle their stomas. And then for us to discharge them at this stage, this is why we want to discharge them, is that their successful adjustment results partly from their own effort. They must have their effort, and therefore that's why we want to train them before they go in for theater, unless in cases of emergency. And if the stoma was fashioned as an emergency, when they come back to our unit, we need to combine both pre-operative and post-operative education at the same time. So we're saying the adjustment might depend on them. It is partly on them and partly from we, the healthcare workers, and also from the community where she's going back or where she's to be integrated back, and also the industries who are providing us with the appliances and the commodities that we need to do. And it's that we remember that once the surgeon has made the diagnosis that surgery is needed and the end product or the output will be a stoma, both the patient and the family and actually the whole community will go into a crisis. Remember, we Africa, it's a taboo that we hardly talk about matters concerning feces or stool in our normal stories. So now there is an instance where now you're telling them that your patient or you now, you'll not be using the normal route. However, your output or your feces will be coming out through your abdominal wall into a bag. They all go into crisis. And especially now where it is probably a mother with the sons, the moment that topic is introduced, the sons almost feel like pulling out of the story, and they want their sisters to come so that they'll be able to handle their mother. And therefore, we say now preoperative counseling and education helps to reduce the stress and expedite postoperative recovery of our patient. Now, the moment this diagnosis has been made, referral of this patient to a stoma therapy nurse is very important. When they're referred there, assessment of the patient is done, and teaching the patient on how she will manage her stoma, that is day-to-day, how she'll live with the stoma in her day-to-day life. And also, the assessment on the family is done, whether they are receptive, are they available, is it accessible to the patient, what support are they going to offer them. And then during the interview or the interaction between the stoma nurse and the patient, the interview is a collaborative venture between the nurse and the patient and the family, where during the sitting, concerns will be investigated. As they are being investigated, you also clarify misconception and you come to an agreement on short-term and long-term goal for rehabilitation of this patient. So it is through this practice, the patients will gain some control over events and thereby increasing their likelihood of compliance with any constraint imposed by the surgery and living with a ostomy. Now, during the time you come, the first contact with this patient, you should maximize to ensure that you have given the best information to this patient, because you might not have another opportunity. Remembering in mind, the picture that you want the patient to have in mind is of such a picture, a bag fitting so well, they're able to do their normal activities. So their capabilities during these interviews and their limitations in relation to living with a stoma are carefully identified to provide the guidelines for the strategies that will be needed to establish their quality of life after surgery. And then we all acknowledge that the aim of rehabilitation of a person with stoma is to return the individual to an independent way of life. We want him to continue doing things. If he was a driver, he should continue doing his business, or he was a teacher. Even MPs and anyone else should be able to be rehabilitated back to this stage whereby the bag is well positioned and able to handle the bag. So it says that preoperative education focuses on the physical changes that are going to take place once the stoma has been functioned, ensuring that the patient and also the significant others, that is the family members, understand what the surgery entails, and that they will be able to manage the proposed stoma and the equipment that will be used during ostomy care. To note that the lifestyle issues need to be talked over in a manner that gives a realistic picture of a post-operative patient with an ostomy. And during this interaction, many other times we use pictures. You should show them the pictures of a good one, well managed, and what happened if we do not adhere to the standards of taking care of a stoma. And then also we as nurses or any person handling this patient at this level should be well prepared enough to answer all the questions that the patient has, and they should be clear answer, and avoid being ambiguous or too much reassuring. Because once you reassure them too much and then they have that clear image of the stoma, and then at the end of the day they come up and get explanation, they wonder, what were you doing that time? So when they are referred to you the first time from the doctor, once the diagnosis is made, the patient will come to you, and many at the time they'll also come with their relatives. If they are with the relative, encourage the relative to attend, to be part and parcel of the seminar or the training that you are doing. And the first question how to handle them would be, what has the doctor told you? And then listen to them as they tell you what the doctor has explained to them. It is a very most important question. This one will promote a positive outlook when clarifying a disease process, and surgery will be beneficial. Then explain that the stoma may be a worthwhile trade-off for their good health. Let them appreciate that it's a good thing for them to have a stoma rather than to stay with the way they are. While at this session, you should reinforce or clarify the information about surgery given by the surgeon using drawings. Yeah, you need to use drawings, and the good drawings to use are some of these ones, whereby you show the patient the normal anatomy of the JT, let them understand this is the stomach. After the stomach, we come to small intestine, the large intestine. At the end of the day, we have the anus here. So if the surgeon has said he will create an ileostomy, help the patient understand where the ileostomy will fall. If it's a colostomy, let them understand where the colon is and how it will be brought out. Then you should dispel any misinformation and misconception that the patient could be having, and explain the postoperative management, describing their own location. Many in the units, we have dummies. And if we don't have dummies, we have images that we can show where the patient, yes, this is the normal intestine, this is how it looks like. And then you go now to the dummy, show them exact location where the wound will be. After you have shown them the image of the normal intestine, and if it is an ileostomy, let them understand the difference between the ileostomy and colostomy, depending on what the patient will be done. If it's an ileostomy, dwell so much on ileostomy. If it's colostomy, dwell so much. So if it's a colostomy, indicate the location where the fashioning will be done. Indicate that it's at, sorry. Show where it will be fashioned. Tell them this is where it will be. And then the moment this part has been sized, and excreted outside on the abdomen, it will appear like this. This is how now the stoma will look. And when you apply a bag, this is how the bag will be looking on the normal intestine inside, on the normal GIT inside. Let them understand that this bag will help to manage the effluent out. Now, then the other thing you need to describe to them is on the stoma. The moment what stoma is mentioned to them, hardly most of them, they don't know what it means. Few people only understand. And their imagination may cause a lot of or needless anxiety. Because the moment they hear that the intestines will be extracted or removed to an outside the body, they think, probably most of them could think it's the whole intestine hanging outside. So you need to clear that one. For you to clear that one, it's always important to show with images. Have a stoma, and at this time, you could be having a patient in the ward of whom a stoma has been fashioned. It's a very important point that you would invite this patient who has a stoma, so that the new patient you are trying to teach might understand how to look like, such that they get the idea that it's not the whole intestine that will be outside. And then explain that once the surrounding wound has healed, that is, this surrounding, it will not be painful, especially if well managed with no skin escalation, it is not painful. And then explain that the stoma once extracted outside, it is not painful, it has no sensation, and therefore they'll just be applying the bag. And then assure the patient that nothing, though there is a hole there, there's an outlet here, nothing can go through this stoma unless introduced. However, be careful with that information, because if they are to go leave the stoma open in the village, dirty, and then probably flies will come over here, they get through, they lay their eggs, and then at the end of the day, you can imagine having maggots or dust coming from this point. Emphasize to them it has to be clean always, and always covered with a bag. When you do not have a patient in the unit with such a stoma, for mothers who their babies are to go for ostomy, it's always good to use dolls or cartoons. Show them this is now your baby, this is where the stoma will be, this is the bag they'll be using. They might appreciate it better if you show them. Then on the appliances, show them that most of them would think now if the intestines are outside and now effluent has to come out, I need a very big bucket to hang around to collect the effluent. No, tell them their bags, their appliances available in the market, actually easily available in the market for them to be using. Well, at this stage, when you're discussing appliances, it's good to have the physical appliances. If you don't have them, use a photo like this one, show them this is how the bag looks like. However, in our sitting, many of the times we have the appliances. We want them to see the bags, to have a touch, to feel them, and even place them on the abdomen to see how it will look like. In our setting, we have very good bags, especially in our institution. Teach them about the bag, help them understand the bag, such that as even they go home, they will not have misconception or somebody telling them I have a bag and the bag they're bringing for them is a wrong bag. It's a patient with ileostomy, it's a colostomy, and then there's a neighbor who was done urostomy, and then probably it was reversed, and now has some remaining bags in the house for ileostomy, and then he wants to give such an urostomy bag to a colostomy bag to use. You can imagine if they use this ileostomy bag, this is an ileostomy bag where you have a valve. For ileostomies is very good because it's the urine getting in and coming out through this valve. Now, you can imagine if you just tell a patient you just need a bag and then they go home, they know a neighbor who had a bag, and then they take this bag, they want to use it as a colostomy bag. It will backfire on them, they lose trust in you, and the quality of life will go down. So tell them we have different bags, show them this bag, it's a closed bag, this one. Help them to understand it's closed, meaning that if the content gets into the bag, through this hole, it will already be retained here. Tell them this is the most ideal bag for colostomy, because a colostomy is formed stool, and therefore as it gets there, we just wait for it to be halfway, then you remove the whole bag and discard. But remind them in Kenya and probably in a resource limited center, this bag might not be ideal for them because it's a one-use bag like this. The moment stool gets there, they need to remove it. And therefore, recommend them for them a better bag, which is this one. It's called, this is a one-piece bag. I'll explain what's a one-piece bag. It has an integrated closure. Closure means here it's the closure itself is on the bag. There are bags that have a separate closure. So for this one is a bag with an integrated closure. Very nice and very good for both ileostomy and colostomy. This bag, if used properly, it can stay on the side for up to 5 to 7 days, and therefore it is very cost effective. It's the bag we are using in our facility and they're easily available. Show them how to close the bag like this one, how you know and you close your bag properly. Let them have a feeling, let them touch the bag. And as they touch, you're building confidence on this patient. Show them how it will be looking like. Then show them that this part, the hole here is very small. However, they need to cut this part using a very designed scissors. And they need first to measure the stoma and show them how to measure. And remember, even post-operatively, where this patient, you're still demonstrating. They cut and then they fit the bag. Just to use an example of a carton here, assume this is a person like that. This is our stoma for demonstration. A stoma is placed there. So if a stoma is there, show them how they'll be placing in the bag like that. They'll be able to appreciate better. And again, also show them the different bags that we could be having and also they're in the market. There's this bag that we have said is a one piece because the face plate is the area that comes into contact with the skin. The face plate and the bag, they are attached. It is one thing. It's very important for them to know. Also remind them, there are bags that are two-piece bags, whereby we have a bag which is separate and we have a face plate which is separate. So what they need to do, it is that this face plate will be attached to the stoma, and then on top of it, now you attach your bag like this. And any bag can be used so long as it is a bag that can stay for long, and avoid ileostomy bags being used for patients with ileostomies or colostomies. Then remind them that sometimes you might get complication. The stoma has come, it is well fashioned, it is 2 centimeters above the skin, but due to some circumstances, the mucocutaneous junction gives way and now the stoma retracts in. Tell them there's also a product for them, whereby you have a face that's convex, they're able to place it on the top like that. During that stage, anything that you have that you think they might need to use, explain it to them, show them such things. We have a stomadhesis paste. Mind them sometimes, even though you fashion a stoma, sometimes as the patient ages, probably a stoma was fashioned when you are 45 years, and now today you are almost 60 years, there's a lot of skin wrinkles on your skin, and therefore the contours or the terrain of the peristomal skin you have a lot of wrinkles. We have a paste that can be used to seal those the areas that are not consistent well. So these ones you need to share with them, and then show them there even some rings that can be used just in an event that a complication arises and the contours or the surrounding of the skin is no longer consistent. The wrinkles have come. They are called rings. And then there are also things we have like as you put your hydrocolloid on the skin, many at the time we find that the hydrocolloid has stayed there, and then as you remove the bag, much of the hydrocolloid is left on the surrounding. It has stuck around. We have removers that can be, they are in form of sprays. You just spray around and the hydrocolloid will come out. And again, we even have wipes that can help to remove. So during this time, make sure that you have explained or given the best information that you think you can give. And also tell them there are hydrocolloid sheets that can be used to wrap around or can be placed around whenever exfoliation happens, but don't encourage them to have that exfoliation. So as we proceed now on the appliances, as you're showing them these bags, remember they have never seen these bags. They're even just wondering, where do I get this bag? Do I have to be coming to the hospital every day to get them? No. Tell them, refer them to the companies that you think they are selling ideal bags, because there are so many bags in the market. You find some of them, they're just using even a PVC material, such that if you put it on the skin, it doesn't absorb the moist or water around or excoriation around, and therefore making the patient have a very difficult time. Show them and even tell them about the prices. Their bag, an ideal bag probably would go for 550 shillings or 600, depending on where you're buying the bag. And during this session, if you have a patient in the ward who is using the bag and probably they have been readmitted, and you realize they stay in the same region, you can call the patient so that they can even help this patient to understand exactly where do we get these bags. And also during this time, it's very important you refer them to any association, it's called a support group that have been formed. We have different groups that have been formed. Even in our institution, we have one. So you only need to refer them. During this sitting, you also need to discuss on issues to do with culture and also spirituality. Most of them would require appropriate or might wish to get an advice from a religious person, refer them to that person. And then they might be concerned that now once the stoma has been fashioned and I have to use bag, therefore I need to reduce or to work on my diet, or I need to be on special diet. No, let them understand that there's no special diet involved in stoma. You just need to eat everything that you're eating before, unless previously you're already on a certain diet. Probably you're on diabetic diet, you still need to stick to that one. And then remind them they need to continue with the normal practices of even drinking water. Remind them, you can ask them, have you ever experienced a constipation in your life? Yes, they'll tell you yes. How was the experience? It wasn't good. Remind them, even as they used to constipate, they will still constipate on the stomach. And it will be very hard for a stomach to remove the effluent if there's constipation. So need to take a lot of water. They'll be concerned that I won't be eating beans because it's associated with a lot of gas, and this bag can't stand the gas. No, let them understand all the parts of a bag. A bag has a carbon small apparatus here that absorb any odor that is coming, and therefore the patient will be comfortable walking with the bag around, even in the car, even in the sports, wherever they are, so long as it is well placed. And we hope that it was sited in a right position, such that not that when they're getting into a matter to oops, it separates from the skin and then the odor starts coming out. Also remind them on the work and play, they need to continue their normal activities, so long as even when they are going in the office. Many of the people working in the offices, even bigger offices, even in the hospitals, and they have their bags on. However, what they do, you just need to be careful and remember your bag capacity. Let's tell them not to wait for a bag to fill. And once it is so full, that's when they want to go and empty. No, once the bag is halfway full, they need to go and empty the bag. So he just be excusing himself from the office, goes to the washroom, empties the bag, and then cleans the area, the area here outside, and put it back. It's very easy to handle that one. Tell them they also need to travel like they used to do, but however, when they are traveling, they need to pack. The first thing, they should pack their bags. They should be having extra bags, and then they should be having a way of disposing these bags. They need a separate canvas bag too, or just this plastic bag, you put it and then probably to be disposed in a pit latrine. Sports, again, tell them they need to continue the activities, sports. However, when now they are going for sports, they need to know how well or how secured is their bag. There are some bags that come properly, like this one that we have discussed, where we have a bag and a faceplate on. This faceplate has a way of improvising, or some of them comes with the belts. So you put your faceplate around that point, and then there's a belt that goes around. You tie it on around like this. This makes sure that your bag, even though it's golf you're doing, as you give the kick, your faceplate is still intact. On their clothing, they will continue dressing the way they were. However, those people who have been using tight clothes might not now work for them. They need at least something free that can accommodate a bag under. On elimination, you need to describe to them the consistency that you expect from each and every stoma there, or from the stoma they are going to be fashioned for. If it's an ileostomy, please be clear to them that in an ileostomy, absorption of the food that you have taken in or you have eaten has not taken place. And therefore, the consistency of your effluent might be more liquid compared to a person who is being fashioned for colostomy, where absorption has already taken place. And if it's an ileostomy, therefore there is need to be emptying your bag more often. As you empty your bag, remember you're losing a lot of fluid, and therefore you need to drink a lot of water. And then also tell them what to expect. If it's an ileostomy, the chance they come and tell you, I ate watermelon, and then within 2 minutes, the whole watermelon was in my bag. Yes, help them to understand that even though most of them will come out as effluent, there's something that is retained in their body, and therefore they should up in taking up their liquids. Most of them will be so concerned about sleep. Now, how am I going to be sleeping with a bag? Tell them there's nothing that has changed. However, you need to be careful before going to sleep. Before you go to sleep, visit a washroom, empty your bag and make it empty, then go sleep. If by any chance it's an ileostomy and at night the effluent is too much, just wake up, go and empty, just like the way you'll go for a short call at night or even long call. And then, demonstrate night drainage system, and especially for our patients with ileostomies. And ileostomy, where you're using a bag to collect urine. Urine might be too much for this bag. So at night, try to improvise with them. You see, this is a bag and a valve. You can connect this one to a urine bag, and then the urine bag will hang around. So the urine will just get in and come out. Don't leave them with so many questions to ask themselves when they go back home, because this one leads to frustration. On the long-term care of the patient, help them understand if you have any concern, especially like in our facility, we have wound care nurses, we have ostomy nurses, and our institution has tried as an institution whereby most of the nurses are going the training that takes place in our School of Nursing. It's a 3-month course. And as a result, most of us will be conversant in handling them. And we also encourage many people to go through this training. It's a very nice training. So tell them if they have any concerns, the best thing would be let them come back here. We know how to deal with them better, other than going probably to a private hospital where they know nothing about it, or if they know it, they don't have their appliances. We have everything. About sexuality, they will also ask a question about that. So be ready to clarify issues that sexuality will continue. However, there is need to empty your bag probably before anything of for having sex. And then if you are to continue that about the communication, most of them encourage them to open up. Let them open up to their relatives, especially the close one or the immediate one. And even as you're doing counseling, encourage to have the relatives close to them. The mother, let's have their daughters there, even their sons there, such that even the sons will know. You know, they might be scared that, oh, now I'm a son, and now this is my mother. This issue of effluent here coming out. How do I help her to change? No, just be there for them to adapt to that thing. And you see, most of them, what they do during this counseling session, they want to bring the house girls on board, or for the house persons who will be taking care of this relative. So you are left with the house person or the house girl who is taking care of this patient. You give all your knowledge, this girl, now she's able to take care of the mother. They go home 2 weeks down the line, the lady decides otherwise and disappears. The mother or the patient is left with no one to take care of. They need again to hire another one to bring them to the training. No, encourage the immediate person to be able to take care of this and empower the patient as much as possible. Allow the patient to interact with the bag, to touch the bag, to put the bag to a stoma, place the stoma. You see, these are stoma. You can put it on the patient's body like that. Tell them, you assume that's your bag, that is your stoma. Have this bag, place it there, well comfortably like that. Then let them stay with it, even the clothes. You can even let them go with the bag pre-op. They go and then they come the following day, they tell you how you're doing. Now for children with stomas, most of them take long, especially probably the children with the anorectal malformation. This baby is growing, a stoma is fashioned when the baby is like 2 weeks. Now this baby probably might have to stay with this stoma even for 6 months and probably so on. And as they grow, they start realizing, I have a bag that is always attached here. They start pulling out. So how do you handle that one? There are these two, they're called rompers, if I'm not wrong, they're rompers. The trouser that you put from the trouser and then it's up to zip up to the neck. it will be the most appropriate for such a patient. And then for reinforcement, ensure that patient generally, and more particularly, the elder may have high level of anxiety and stress during preparative interviews and may well have difficulties recalling what you have discussed. And therefore, for these ones who are older or a bit older, always encourage them to come, that they come with their children or their significant others, because you'll tell them something today and tomorrow they have forgotten completely what you said, because their memory is also going down. Then during the session, if you can try and have more of audio or written materials that reinforces preoperative education for the patient and family members to review even at a later date. As you can give them material literatures. If you have a video, you can give them, you can tell them maybe to watch on YouTube, such that as they will be giving feedback to the other people at home, they'll not be like, what? This one now will be having issues with faces or stool. And then for illiterate people, you need to reinforce the information in form of the audio tapes. Now, the biggest thing now comes on where we talk about now stoma selection. This is purely for us healthcare workers. However, we need to do it as a team and incorporate the patient and also the relatives there. And we all agree that a well-sited stoma is the key to successful rehabilitation. If a stoma is well-sited, a place where when you place a bag, you place your appliances, it sticks there until you move, that one leads to a successful rehabilitation. If poorly sited along the belt line or the waistline, you bend a bit and then the whole faceplate is this top part, gets creases and then the effluent starts seeping out, that one leads to a lot of frustration. And we all agree that a patient or an individual with a stoma must have confidence that the appliances will not lift off or leak unexpected because of a problem with the location of a stoma. This patient have gone from somewhere in a wedding, and then all of a sudden, when dancing, then the appliances is off. And then over the beautiful clothes that they had, the beautiful dress they were on, it's all now wet and soaked, and now the smell is there. We need to set it in a place that it will be comfortable for her when she bends, she walks, she sits, she lies down. And then he or she, this patient must be able to resume the normal lifestyle, secure in the knowledge that activities of daily living will not be interrupted. If she was Mama Mboga, she need to continue with her business. She need to continue selling. He was a butcherman, need to continue with his life. A teacher, the same. And then we are saying that an ostomy, or stoma placed in a poor position on the abdominal wall, can make life very difficult and very frustrating. And the anxiety that will be generated by the threat of a leaking appliance that soils clothes or allows escape of an acceptable odor has the capacity to frustrate and any attempt that the person with a new stoma may make to resume a normal lifestyle. And then remember the embarrassment about the odor and soiling may progress into a social isolation. You don't want to go to church because you are fearing that it might leak and seep out, and then the whole church all of a sudden goes into a very bad smell. The physical discomfort caused by the sole, that is peristomal skin. Remember the skin where we were showing the peristomal skin. The pain or the discomfort that comes with that peristomal skin escalation, or that results from a leak on a stoma, or shearing of the skin, caused by a constant change of appliances, may trigger clinical depression. And therefore, that's why we insist, give them or show them the right bag. This is a closed bag, and therefore, every time they use it, they need to remove it. Imagine a patient with ileostomy having to use this bag and remove it. The more you keep on removing, you're also interfering with the integrity of the peristomal skin. And therefore, tell them to use the right bag, a bag that is open, it is drainable, has this integrated closure, and it will stick there better. Now, we are saying that a stoma that is well sighted is a stoma that the patient is able to see it when lying down, sitting, or even standing. So on abdominal stoma are sighted away from the suture line. You remember, for us to develop this stoma, there must be a suture line somewhere. There must be an exploratory laparotomy done, and therefore we have a suture line here. So if you have a suture line here, and this is a patient you are dealing with pre-operative, you need to let them understand this is the expected area of the wound. This is where the incision will be. And therefore, as the doctor will be fashioning this stoma, he will be very careful not to have a stoma along this line. So this stoma is usually sited at that of the way along the marginal line drawn between the umbilicus and the iliac crest. This is where the iliac crest is. This is the umbilicus. So the stoma, properly sited one, is usually at that along this imaginary line that we draw here. But remember, there are challenges while citing this one, as we'll be discussing them thereafter. And be prepared that even though you cite here, you mark here, you have agreed with the surgeon that you'll have the stoma here, he might go in and find other difficult thing or some difficult procedure inside, and this stoma might not even end here. It might even end near the iliac crest. Just remember, if it's like the iliac crest, it is hard to manage. But if it's hard to manage, do we leave it at that? No, we should be prepared. We have repeated and said that the stoma should be clearly visible to the patient when they are standing up, sitting, to facilitate management. So as you're doing sighting, we need to do it when the patient is seated, when lying down, and when standing, and they should be able to see this stoma. Remember, they are the one to manage, they are the one to put the bag. Then we are saying a good stoma should always be supported by the rectal sheath. This is the abdominis rectus muscles. This is where we fashion the stoma. How to detect these muscles? When the patient is lying down, place your hands along this part, the abdomen, the two hands, and then tell the patient to cough. You realize there is tightness around this area. Means that is where the rectal sheath is. So fashion your stomach to be around this place. So, and then we are saying the appliances should lie on the abdominal wall in a position that is free of risk of the faceplate adhesion and is invisible through the clothing and allow an obstructed drainage of the stomach. This is the right place. So notice this one. Yeah. And from our imaginary person here, so this is the abdomen, we assume. This is the incision site. This is the incision site. This is the iliac crest. So we are saying it is 5 centimeters away from the incision site. So around this area, this is where it will be so marked there. And for you to mark there, you need to place your hand on the iliac crest and also on the umbilicus. Then we are saying a third. It's where you should fashion. So at this area, a third, that is where you should mark your stoma will be around that place. So ask the patient whether they are able to see that point when they are lying down. They'll say yes. If it's okay, tell them to sit. Ask them, are you able to see the place? Yes. Tell them to stand. Are you able to see? If they're able, just know you marked the right place. And then you also need to discuss the surgeon where you have marked that place. Then there are challenges. You'd really be willing, or anyone desire would be to function a very nice stoma on the abdominis muscle, abdominal rectus muscles, this one. However, due to the age of the patient, you find the challenges. You're not even able to sight properly because of this. These are some of the challenges you'll find in life. Now a patient comes, is a 67 years old or even 8 years old patient, you need to fashion a stoma, but the wrinkles, these are how the wrinkles are, the abdominal muscles. So these wrinkles will give us a problem because even the stoma, there will be no proper contours because of these wrinkles, but we have to deal with them. Another patient, you want to, just to mention, this is the ideal person that we desire. We make an imaginary incision line here. We do from the iliac crest to abdominis, so around this place, we'll be having a stoma. But now you go and find this a patient who comes with this distended abdomen. How do you fashion a stoma? It becomes a challenge. Another patient who is very hard to, when doing stoma sighting, is a patient who is on a wheelchair. This one you need to be very careful. You need to put a stoma that they are able to manage while they're in this position. So what are the steps in stoma sighting? The stoma is that you should first, as the patient comes to you, you should assess the abdomen with the patient fully dressed. And as they are dressed, your image or what is the picture in your mind should be this one, that I'll be able to locate these muscles well. And then you should mark any skin creases or scars. Identify those scars and make sure the scars or the mark you're putting on the creases, it's not the same mark the one you're putting where you want the surgeon to fashion the stoma. And then identify the rectus abdominis muscles. We have said these are good rectus abdominis muscles. Me and you desire that our patient can have such a thing, such that when you fashion a stoma, these muscles will help to anchor or secure the stoma outside so well, even when the mucocutaneous junction gives way. Then once you identify these muscles, you make a 5 centimeter away from, you make an incision. There's an incision here. So 5 centimeter from this umbilicus is around this point, this line here. But now remember we said we need to make an imaginary line between the iliac crest and the umbilicus, and at that, this is where we place the stoma. So site mark should be seen by the patient. We repeat again, and then mark sites on both sides of the abdomen. Both sides, the surgeon, when they go in, you might wish they do it on the side that probably you like on this side, but mark on both sides. Then cover the mark where you have made the mark. Cover that mark with a transparent dressing, and assume now that is the stoma. And tell the patient, try to put your back here. Try to let them understand this transparent dressing will be like the stoma that will be fashioned like the one we have here. This is the stoma. There, you can even put a bag and let even patients stay with that bag even for overnight. Then the following day you come and ask them how it was. Then as you do that, you must always confirm the best choice by having the patient once again sit and stand or even lie down. I hope I'm clear on stoma sighting. Now, in conclusion, when all is said and done, preoperative counseling done, intraoperative care done, postoperative care done, we wish and we desire to discharge our patient at this stage, where they'll put on their comfortable trousers they love, the skirts and everything, their top. This top is free enough and loose enough to cover this back comfortably. And as we go on, now we are looking at could we have bags that are coming now designed with designs that a patient can even be comfortable. Today they can even change to put on a pink one, tomorrow a red one. And I think they'll be happy with that one. And I think with that, I've come to the end of my presentation. Thank you so much for your time.
Thank you so much, Mungi, for your presentation. Our time is almost up. We'll take a few questions. The first one is from Ruth Jahonga. Good topic. My question concerns handling adults using diapers. Can we have a presentation on how to manage such patients in home settings?
All right, thank you so much for that question. So the question is on using diapers on a stoma.
Yes.
Now, that's a practice we wish to discourage from now henceforth. The stoma or the pampers, the diapers, they do not have the capacity to absorb all that moisture or that effluent that is coming out from expansion and ileostomy and even colostomy. So what happens as you put it there, the skin or the peristomal skin still gets irritated with the effluent. At the end of the day, this is the patient who will come with a very bad peristomal thereafter. So that one we discourage and we say, let's use the bag. And even when you are discharging the patient, discharge the patient home with a bag. You'd rather retain the patient until you get the bag other than sending home with a diaper. I hope I've answered.
Yes. There's another question from Jen Ogiero. How affordable are the bags and what happens to patients who can hardly afford?
Exactly. Thank you very much for the cost. Cost is very important. Do not discharge your patient until you're able to refer them to the most appropriate place to get a bag. There are so many bags in the market, bags that are cheap, even 300. However, it's a bag that is like this one. It's a closed one made of PVC that will not help the patient. Our bags, most of our patients, we have been referring them to the company that provides KNH with bags, and so it's called Coloplast. Coloplast, the last time I had, probably last week, they were each a good bag like this one, the ideal, like the one we have in KNH, goes for 550 shillings. However, there are other shops in town, you'll get the same bag with around 800. So if you could refer them probably to the company and itself, it will be cheap for them and affordable.
There's also a comment from Lion Sally. I've witnessed a lot of patients going into depression as a result of shock due to trauma. Their classes are also not readily available in Kenya, and if one is lucky to find, then they are quite costly. Can Kenyatta lobby for these appliances to be available to the patient even after discharge?
Wow. A good concern. However, in KNH, currently, I don't think we have a challenge with our bags. All our patients in the unit, they have bags. And those ones that we have been referring them prior to Color Plus, we have not been having issues. But remember, if the patient can only use this bag, that is 550 shillings. And this bag can go for 5 to 10 days, 5 to 7 days. However, if you do not manage well and then you introduce diapers because the patient cannot afford, now with the skin exfoliation, you need to go down now and start using the stomal powder. Stomal powder, one thing, it's nice, suits the skin, but it's damn expensive. A small bottle of this goes for around 2,000 from the companies, meaning from a retail shop, it is much expensive. So let's use the bag and stick to bags only. And if you only stick to bags, there's no need of you even using the seals. There's no point of using even the rods. And as you said, they are not available on discharge. Remember, we are a hospital institute. We might not give them on discharge. We just need to refer them to where they can get them. Because if you give them on discharge, you have not charged that bag. Tomorrow, the institution will not be able to provide us with bags. So just refer them.
And the second last one from Jane. Do you come across patients who cannot cope with the stoma?
Yes, we do, and many of them have come to our place, and especially, sorry, on a lighter note, stomas that have not been fashioned here, most of the patients are coming, and when they come, many at the time we find that probably the stoma was not well fashioned, it is on the iliac crest, and even placing the bag is not even possible. So they are there, but our patients from KNH, we haven't seen many of them with that challenge of not coping, because counseling is done in ward and also in the clinic. And then we have an outpatient clinic at Clinic 24, where continuous counseling also happens.
The last one, what from Shanta, what can one use on a patient with a stoma but allergic to the bags or the materials used?
What can somebody use on a patient who is allergic to the bag?
The materials.
The materials. Especially the allergy, it's not really an allergy. What happens is when you use a bag that is of poor quality, and especially bags that are made of PVC, a PVC is not able to absorb moisture around the peristomal skin. So what happens, that effluent or that moisture continues irritating the skin and probably start linking the patient with allergies. However, if you use the right ideal bags, the ones that we have here in KNH, the face plate is made of hydrocolloid. Several studies that I've seen, most of patients are able to tolerate hydrocolloid because it has, I think it will need another presentation to discuss on the component of the hydrocolloid. However, it has the hydrophilic region and hydrophobic. Hydrophilic, it's water loving, once placed on the skin, is able to retain moisture. And as you place it, you find it is very thin. And as you'll be moving it, you find it has increased in size because it's able to absorb the moisture. And as it retains the moisture, it bulges out or it retains moisture. And such a patient do not have issues with exfoliation and there's no allergies. So I haven't had a patient who is allergic to hydrocolloid so far.
That's all for today.
Thank you so much.
Yeah, thank you.
So we look forward, we'll be doing a series. So next presentation will focus now on the intra-op or post-operative care of this patient. Thank you so much, Valiant team.
Thank you all for the good comments. We're moving on to the next series of enlightening nurses on how to redeem your CPD points. Remember, can take up the series.
Good afternoon. We are going to go through the process of obtaining our CPD points from the NCK portal. This is for the nurses. We have the question and answer section where people are asking how to go about logging in to view to upload your CPD. So I would encourage you to work with me as I give you step-by-step steps on how to get your CPD points. Go to NCK portal, log into your NCK portal. When you log in, you'll find that screen that has you download your license, curfew pass, auto mitigation. It is a dashboard from Nursing Council. Then on the bottom, you'll see a red button written to log in to view courses. You will go to log in to view courses. Once you log in to view courses, you will see a button written add live event. When you go to add live events, there is a space where there is a button that says you put the code. The code for today is good. We are there, add live events. Sorry, our internet is a bit slow, but we are almost there. You will see where it is written secret code. Put the code for today's code is capital B, capital L, capital N, capital K. Once you have put your codes, validate the codes. The code has been validated. After that, go to submit the code. It is showing saving. On your end, it should be showing the same thing, saving the code. The code has already been saved, and you will see on your screen, it will show your education tracker. On 18th August 2022, the latest one, you will see we have updated prevention and management of pressure injuries in ostomy. It has awarded you 1.5 points. So you will go back again and download, export your summary. It has been exported. You will see it in your desktop if you are using a desktop, or on your screen. It is there, CPD report PDF. Go back to NCK portal at the dashboard, or you can log in again into your NCK portal. Once you log in again to your NCK portal, we are still at our NCK portal, logging in the second time now, so that we can complete this process of uploading the CPD points. The CPD points expires in 48 hours. Like this one will be expiring in 48 hours after this. So please ensure that you have logged in. Once you are there, we'll go to the icon CPD points, click on the CPD points. Go to self-reporting tool. I hope we are still together. Once you go to self-reporting tool, click again on the self-reporting tool the second time, and then you'll have a screen that appears like that. And it will require you to fill those details, the event category. So you will click, there is a drop down, and you will go to online, the second last accredited online CPD activities program, click on that. Then you'll go to the next event attended. You will enter the title. Click on that. It was on pressure pre-operative management. It was an online event. The location, it is in Kenyatta National Hospital. Please put it in full. Don't put in shorthand. Kenyatta National Hospital. The date attended is today. August 18th. Then you'll see a press written upload CPD evidence. Go to choose file. On your desktop, there was the CPD report PDF. That is what you're going to upload. So attach that CPD. The CPD report that is in PDF. You can see the one that is written, the CPD report PDF. That's the file that you're going to attach. Once you click on it, click open so that it can attach. Then submit to NCK for verification. You will not get the points immediately, but they're already in your portal. But by tomorrow when you check, they'll be uploaded in your portal. You have already submitted your CPD points. They'll be able to give you, and it will only come to you if you have attended the events. If you have not attended, they will tell you have not attended. So don't steal points from other people and think it is going to favor you. I'm sorry. So it is telling you that the points are, please allow 48 hours for review and login to see the approval status. Do not submit the same CPD report more than once. We have already submitted, so we will wait for 14 hours so that we can check. They will be updated. That is all about CPD points uploading. In case of any question, you can reach us in cpdnursing@knh.com. Thank you so much.
Thank you so much, Remember, for taking us through the process on how to claim our CPD points. It's very important. And if you still have a challenge, in KNH, we are ready, available for you. Come to our office. We're in Nursing Standards office. That is in 6th floor of Tower Block between 6A and 6B. So if there is no other question, I take it back to the moderator.
Thank you so much for everyone. Thank you, everyone. Thank you for your participation. We've ended today. Thank you so much. Have a good evening.
Very welcome. Thank you to the presenters today who have been given us the session on stoma. For the upcoming sessions, we'll be resuming next week on Tuesday, and we will be reviewing arthritis, followed by another nursing series session on Thursday. For the CPD points, I think for the NCK have been handled, but for the PPB, we are still working on fixing that. We are in communication with the PPB board, and the issue of invalid tokens will be sorted soon. But in the meantime, just keep visiting the portal and subscribe to the events that you had attended to previously, and also the new events that will be posted. And we will be sending the CPD points through email. Thank you so much for joining us today. We look forward for the other session on Tuesday.